node, and that's why they get to stay underwater for an hour and we don't, because we've mostly lost that reflex. But it's still there actually in kids. It's pretty easy to elicit, and so that's one of the reasons why ice works. It slows down the AV node. Valsalva maneuver does the same thing. It causes you to increase your vagal tone. Your parasympathetic system kicks in, slows down the AV node. Carotid massage, same thing. Some people will do, if you push on your eyes, you kind of do that. I don't really recommend that one. People do that. And carotid massage we don't do in adults because adults have plaque in their carotids. Kids probably isn't a big deal. You only do one side, not both at the same time. I think that came up once when I was a medical student. We were like, what do you think you're doing? You're cutting off everything. Don't do that. So the vagal maneuvers, the next step, if that doesn't work, is adenosine. Adenosine blocks the AV node. So it actually very temporarily stops the AV node from functioning. It literally stops the heart. Luckily, it lasts about 6 to 10 seconds total in your body. And that's why we're always like, do you have two-stop? Do you have stopcock? Do you have a big flush? Do you have a big syringe? Slam that thing in. It doesn't help to be gentle, because by the time it gets through your tubing, it's already stopped being active. It was only active about 6 to 10 seconds. Ibupropanamide, that actually works on the accessory pathway, and that actually changes the conduction property in the accessory pathway. So when we fail with adenosine, we really can't get somebody under control with that. That's one of the things we sometimes see us try. Usually we're in the ICU, but not always. We've definitely, I'm sure we've given it, I know I've given it in other ERs, I'm sure we've given it in ours. Long-term beta blockade, propranolol, that's really, propranolol is typically the one that we use. That's typically going to kind of overall slow down. It slows down the overall heart rate. And so what it does is it doesn't so much block at the AV node, but what it does is it slows down the whole pathway, and it allows us that, if you have your tachycardia, maybe it's not going to be so fast. And it allows, again, because of the timing of the heartbeat's different, it allows your own native, premature beat, skip beat, your own change in heart rate to kick in, a vagal maneuver to be more effective. And so long term, while we're medically managing somebody, we're going to use something like a beta blocker. We don't use DIG, though you can use DIG, but we don't typically use DIG, especially when somebody's first diagnosed. And that has to do with the fact that DIG actually slows down the conduction in the AV node. And it can. It doesn't slow down the conduction in the AV node, it speeds up conduction in the accessory pathway. And so what it can do is actually allow a fibrillating atria to conduct more easily through an antegrade accessory pathway. And that's why in WPW specifically, we try not to use DIG. I've seen it used a couple times for whatever reason in a newborn, and that's probably because the risk of AFib in a newborn is extremely low, but after a year of age, we definitely do. We don't use DIG unless we know for sure that this is not WPW with that pathway that can go antegrade. If it's just a regular old accessory pathway that can only go backwards, then DIG is reasonable. But if we don't know, or if we know that it's WPW and has the potential to go forward through the accessory pathway, DIG is off the table. Propranolol can cause hypoglycemia in babies, which is the other reason we sometimes don't use it in kids, because and it can I don't know that it really has the same potential. Other beta blockers sometimes cause depression in older kids. Atenolol is a little bit more known for that. Propranolol, I don't think I've seen that much, but it's reported in the literature. After kids are a little bit older, this has changed even in the 10 years since I was a resident. We never did ablations when I first started in cardiology. If you were a teenager. Now, about 4 years of age and above, the catheter size has gotten better. So the catheters are getting smaller. We're doing more of these. We're getting better at it. Our intracardiac mapping is better, so we can see where these electrical misfirings are happening. We can find those accessory pathways a little bit better. So now actually down to about 4 or 5 years. It's still pretty, the risk is a little bit higher at that age. I still like to get kids a little bit older if I can, but at least if we can get them to 15 kilos, we think their overall risk goes down. And then go to that in a second. And then as far as long-term management, this is pretty well managed. You know, kids with this, I mean, you'll think you guys, especially in the ER, you see these kids come in sick, but you don't get to see them go back out. You know, that baby that's gray and looks horrible in triage, who comes in and you give adenosine and their heart's function looks terrible, and we're all at the bedside, you know, mumbling and grumbling, goes to the ICU, and over time, generally recovers. You know, most of the time, once you take that tachycardia away, once you give the time, you give the heart time to relax, recover, and to fill appropriately, a lot of those things do get better. It's not that everybody does, but mostly. Yeah.
I've recently heard about a couple studies where when you do like the vagal maneuver and you like raise their legs afterward for like 15 seconds to a minute, it like doubles the increase in like
vagal.
And yeah,
So
in working along with, and the same thing with adenosine, but it was more impressive with the vagal maneuvers because then you completely avoided the drugs.
right.
Have you heard about that?
I hadn't actually. That's really interesting. You do when you know what one of the things you do when you lift your, and actually one of the vagal maneuvers I did put on here is a headstand. I had a 13-year-old who did that, and that she knew when she had her tachycardia, and she would literally do a headstand up against a wall. And I was like, always have a spotter, please. Spotter. But she could do it, and she would pop herself out of that. And I bet part of that is increased return, blood return to the heart, so you get a little bit more filling. You actually do kind of get that, you know, carotid filling, which also causes a vagal stimulation, which also kind of elicits a vagal response. And so I bet that makes totally good sense. It's not something we've done very typically, but it would make a lot of sense along with the vagal maneuver to kind of get more blood back to the heart. Like I was saying, so long term, I think most people do really well with ablation, as long as there's no recurrence of tachycardia. Sometimes what can happen is you have one accessory pathway that's dominant. You find that one, great, you burn it, and 3 years later, another one kind of decides, it's my turn now. It's pretty unusual, double pathways or you know, kind of more complex accessory pathways, but it's possible, and we definitely see that. We'll talk a little bit, it's already 5:30, so we'll talk really kind of briefly about ventricular arrhythmias. And the reason I can talk about these briefly is these are much less common. We just don't see them very often. And most of the time, these ventricular arrhythmias, and that's going to be, you know, different types of ventricular tachycardia and VFib, are secondary to something else. They're not necessarily, it's very unusual to just out of nowhere have a ventricular tachycardia for no reason whatsoever. There are a couple instances, and we'll go through some of those, but it's pretty unusual. The ventricular tachycardias typically are going to be wide complex. The wide complex tachycardias, if you kind of remember our prior sort of stratification, suggests an origin below the bundle of His. It generally has a worse prognosis, usually because there's already some reason for those ventricular cells to be active up. There's something more than that. It's typical to be an abnormal myocardium, whether it's abnormally thick or it's after a heart attack, and that's ischemic tissue, but luckily it's much less common. These are some of the kind of ones that we do see. The first one on that list, I've seen both of these first two, very, very rarely. And the good thing is the slow transient, and both of them tend to get a little bit better if they're seen in infancy. In infancy, this we're talking before a year of age. Slow transient VT is a kind of a weird phenomenon, and not uncommon in I shouldn't say not uncommon. Typically, we're going to see it in a newborn baby, and it's a wide complex rhythm, a ventricular rhythm that is a little bit faster usually than normal, but not terribly fast, around 200. So not something that a baby couldn't tolerate, but sort of certainly faster than we would expect. And it's transient. It tends to go away on its own. Oftentimes you don't have to do a whole lot for it. Maybe some rate control if somebody's a little bit sick. Rapid incessant VT in infancy is much more concerning and also much, much more rare. And that actually requires either surgical or catheter ablation. And actually surgical ablation more commonly because the catheters are just so small. The kids are just so small, the catheters are so big. The other kind of common things that we see, and again, these don't have you know, they don't have wide complex tachycardias or ventricular tachycardias all the time, but they are what set you up, or what set people up for the ventricular arrhythmias or VTAC. Long QT syndrome, Brugada syndrome, and something called catecholinergic heart CPVT, or CPVT. And that's where, with exercise, with anything that gets the heart rate up, whether it's, you know, I'm excited, or whether it's my alarm went off and I was dead asleep, that puts people into a ventricular tachycardia that's a real, it's a true ventricular tachycardia that can be life-threatening. You know, not at all uncommon in congenital heart disease. So where we see it is with kids who have abnormal hearts for whatever reason. Their pathways are, you know, they're missing part of their heart, and so their conduction pathways are also abnormal. Or they have abnormal myocardium because of how their coronaries are. And so we see those areas as kind of niduses for abnormal ventricular activity. The cardiomyopathies for sure, hypertrophic cardiomyopathy being the more common one, but certainly a dilated cardiomyopathy. These are the kids that come into the ER. They, you know, the dilated, for example, is very commonly the teenager who is totally fine, but has been feeling really crappy, and they have some weird PVCs popping through all over, and then they have a run of VT, and then they stop, and they just have these really irritated, poorly functioning ventricles, big and dilated, that, you know, it kind of comes out of the blue, idiopathic, and that's really one of the more common times that we see ventricular tachycardia. Myocarditis can do the same thing, so an infection of the heart muscle, usually a viral phenomenon, usually a viral infection, can irritate the heart, can cause poor function, and then that poorly functioning myocardium just doesn't respond to signals appropriately. The thresholds in those cells, all the electrolytes or the ions get they aren't in the appropriate place. Typically, again, calcium. One of the reasons we give calcium code, besides that, in a lot of babies, calcium, their hearts are more calcium dependent as far as contractility. That helps their contractility, but also because their membrane potentials. Calcium is one of the things that really stabilizes the membrane potential. So sometimes you'll see us say, you know, you've given calcium and given calcium. We're like, and you're like, the calcium's normal. I'm like, give some more. It doesn't matter. Like, see if we can stabilize those membranes. And so you'll see that. Idiopathic VT, very unusual. Sometimes ventricular tumors. Again, something that irritates the myocardium. And ischemic heart disease, which thankfully we don't see very much of. Every now and then in a Kawasaki's, post-Kawasaki's with an aneurysm, we'll see a 6 or 7-year-old have an MI, but it's very unusual.
How often have you seen a tumor?
Tumors are not unusual. So tuberous sclerosis, for example, rhabdomyomas, you see them, I mean, again, it's not super common, but you definitely see them. Fibromas also, fibromas tend to touch the wall of the heart, typically more atrial, but so you can have them in the ventricular mass as well. Hamartomas, which I think I've never seen, but I've read about, can do it. And those are typically in the ventricle. Like histiocytoid tumors and things that you see mostly in adults every now and then, very rarely you read about them in kids. But those could do it as well. Typically they can be either monomorphic, meaning they're coming from one set of cells, they all look the same, or polymorphic, multiple areas that are misfiring, that's a little bit more worrisome. Bidirectional, meaning that they're kind of they're sending signal forward and backwards, and that's typical of CPVT or catecholinergic VT, and then oscillating, and that oscillating is torsades, and I've got pictures of these for you. One thing that I put down here at the bottom that's really important is not all wide complex tachycardias are ventricular. Sometimes you get that kid that's like 13, he doesn't feel great, his heart rate's 200 and it's wide complex, and you're like, how are you not dead? Why are you not dead? And it's actually, it's an SVT, it's an atrial tachycardia that's conducting aberrantly down through one of those pathways so that it looks wide, but in reality the ventricles are handling it fine. It's not that there's disorganization of the ventricular contraction. And so that's one of the times, sometimes you'll I've definitely had somebody say, call me up, I've had a resident call up in a panic, like, oh my God, this guy's, 250 and he's in VTAC at 250, and I was like, why aren't you coding him? And they're like, he's talking to us. All right. So it can be a ventricular tachycardia. CPVT can sometimes do that, but yeah, why are you not dead? But a lot of times that'll be SVT with aberrant conduction. This is that scary wide. I like this one because it kind of goes wide, narrow, wide. And so this patient actually was coming in and out of her ventricular tachycardia, so wide complex tachycardia, and then would break on its own, and then she'd go back into several more beats. Sustained versus non-sustained. So this would be something called non-sustained. It happens, it lasts several beats. She pops out of it on her own, as opposed to sustained, which is just a persistent tachycardia. This is torsade. Torsade we see not uncommonly after long QT. One of the scenarios that you can envision and that you guys would see first is the kiddo on antipsychotic meds who comes in with diarrhea or some profound illness, who hasn't been eating well, who's maybe whose electrolytes are a little bit out of whack. You didn't ever see, and then they come in and you're treating them, and you give them something for a viral an infection. You something like azithromycin, which prolongs the QT even more. And they're already on an antipsychotic, which without us knowing their QT is already prolonged, we just prolonged it more, and then they go into torsades, and there was no rhythm, nothing to suggest a rhythm problem before. But torsades is this oscillating, just sort of the point. It's turning around a point, and basically it's the electrical activity is kind of going down, around, and then up, and then around, and then up. And that's a very I like this picture because it's really classic for torsades. If you see that map, again, stabilizing, we don't think about it, but what we're trying to do with calcium, with magnesium, and potassium is we're trying to stabilize that cell membrane. We're trying to change the thresholds of those membranes so they stop firing. But amiodarone is one of the drugs that can cause you to go into torsades. Every now and then, once in a blue moon, nothing works. We give amiodarone again, and it puts somebody out of their torsades. But typically, that's our concern with amiodarone. And magnesium is one of the ways that we manage that. Wide complex tachycardia is